Good morning. Thank you, Jan, for the introduction, and thank you for inviting me to speak about partner notification. There's people who say I'm the mother of partner notification in the Netherlands. I'm not sure. But I indeed work in this nice city at the Public Health Service, and a lot of what I'm talking about is about the results of the STI clinics in the public health services in the Netherlands. I do not have any disclosure. I will speak about partner notification in chlamydia and about partner treatment in chlamydia and about HIV. Of course, HIV, syphilis, LGV and hepatitis C are priority diseases where we should put a lot of effort in for partner notification, but I will just keep it on HIV in this case. Partner notification is, this depicts a person with an STI. Partner notification aims at preventing reinfection and also the further spread of transmission. Partners can be warned by the index personally, by phone, by a contact slip, or by a SMS or an email. And of course, we want them to get tested and treated. In HIV especially, partner testing is what we want because we want to find cases and we want to refer them for treatment. Most of you will experience that, as chlamydia is the most common bacterial STI in our clinics, that we have limited time for partner notification, and usually partner notification in chlamydia is left for the patient. In the United States, expedited partner therapy is widely permissible legally and done in a lot of states. Partner treatment to the patient with chlamydia is provided without seeing the partner, without having any contact with the partner, either by handing out medication or a prescription. A meta-analysis, which is done by Ferreira and also in the review of Althaus, showed that reduction of reinfection in index cases, so the individual effect of this partner notification with curable STIs, they showed that EPT is more effective than patient referral. They also looked at enhanced patient referral, for example, by more intensive counseling, using booklets and referral for an infection-specific website or test kits. But they could not show any evidence that EPT was better than enhanced patient referral. There was one large RCT done by Matthew Golden in the States, which is published in 2015, and they implemented EPT very large scale in their state, and they saw that population prevalence of chlamydia decreased a bit, but not significantly, and they couldn't prove that it was the effect of EPT only. In the UK, EPT as done in the US is not permissible by the law. And Claudia Escott is working on APT. In APT, there is a contact from the provider with the partner. They phone the partners to assess allergies and contraindications and so on, and then patients can get prescriptions or pills, collect pills in the pharmacy. They found an effect of APT in their first study, an increase of partner treatment when they used the hotline or when people went to the pharmacy. But the recruitment rates varied much between sites and staff satisfaction, so the results were not what they had hoped to achieve. In the Netherlands, we did a study, Pick Up, patient-initiated partner therapy, where we wanted to assess what the potential of PIPT would be in chlamydia in our country. And we did that with GPs, STI clinics, and here I show you some results of the professionals. Professionals all thought partner therapy of at least the current partner is very important and we should really go forward with this. But most of them also said, we want to talk to the partner, we want to do counseling, we want to speak with these people, we don't just want to give out pills. When we asked them if what partners should be treated, almost 100% said they would treat the current partner, and they do when the partners come to the clinic, but they were much less inclined to do partner therapy in casual partners. And when we asked them, and you see this in the green blocks here, would you give medication for the partner for the index patient, the percentage who would do that was much lower. We also, in this project, we also interviewed 40 patients with chlamydia and notified partners for chlamydia. And as partner notification is the basis before we can do any partner treatment, we also asked them what their experience was with partner notification. And we found a lot of differences, whether it was the casual partner or a regular partner or an ex-partner. Whether it was a new partner, people were quite often happy to tell their new partner because they are still in love and emotionally affected. What we also found was that there was a lot of cultural differences. In Rotterdam, we have quite a multicultural population, and we try to interview people from all kind of different backgrounds. And we found a lot of differences there. For example, from I'm not going to warn any ex, and some didn't want to, like Islamic people, an Islamic man wouldn't want to tell his wife that he had been diagnosed with an STI. What did they think about partner treatment and giving prescription and pills? In contrary to the professionals, they were quite favorable. They said, give me this pill, I want to have this. They said, it may help me to notify my partner because I bring kind of a solution for home. But they were also worried, and that was funny, that they were thinking, some were thinking quite far about unnecessary treatment, untreated other STIs, or breaking the notification chain. So many of them said, why can't we get a test and just take the test with us and the pill, and maybe get the partner first tested. This concern we found was maybe not really not a stupid concern, because Fleur van Aar, she analyzed the STI surveillance data in the Netherlands in some years, and we found that all those notified for chlamydia where 34% were positive, meaning if we would treat all those notified for chlamydia, we would have quite a considerable overtreatment. In those, we also found 1.2% of gonorrhea. And that means if we would give this partner treatment for azithromycin to those notified for chlamydia through the partners, and we would not test them, we would miss 10% of the gonorrhea in our STI clinic population if we would not test them. So I think we need a balance between unnecessary treatment of chlamydia and potentially missed STI versus untreated chlamydia. And what we heard also from the professionals, they were quite willing to give PIPT to people who would otherwise not turn up at the clinic. Our legal situation is comparable with the UK, and we found that there is a way we could do PIPT, and most favorable it would be in the STI clinics at the public health services. We could in the end give pills to the index patient after we had contact with the partner, but we do not need to know details of the partner like name and address. But as I said before, there was no support for a large-scale introduction of EPT in the Netherlands. How is it going elsewhere? I have read quite some papers about the real-world implementation of EPT, and quite most of them, they found that EPT has indeed an effect on reinfection, but it's not very much used. It's always in most clinics around 50%. Kees Rietmeyer, who is sitting here in the room, has done a study in his clinic in Denver, and they forced people to document EPT, and that alone, that you had to document EPT, raised the use of it from 20 to almost 50%, but it was not higher. Oliver did a study, and he studied more than 400 women who were chlamydia positive, and he found only 85% got treated themselves, and only 31% of those were given EPT for any partner. So the use of EPT is quite low. Once you use it, whether you use medication or prescription, around 80% of those partners get treated. This prescription EPT has some other issues. Recently there was 2 publications. Here one in Baltimore where EPT is legal. they speak about pharmacy deserts. What they mean here, what you see in this map here in Baltimore, the orange parts are the highest chlamydia prevalence in the area, and the red dots are pharmacists who don't know about EPT and that EPT prescriptions are legally possible. There was another report where pharmacists were refusing legal prescriptions. So the question is, does prescription EPT lead to partner therapy? And maybe we need additional studies to compare this better, the direct medication or prescription EPT. In some states in America, the public health departments purchase and distribute EPT, but that is, of course, costly, and that's one of the issues also with EPT. It is costly. And what I think is also important is that studies are having good effects, but what is in the reality, an intervention can be working out very differently, and real life has implementation issues. So the question is if real life EPT does maybe not lead to expedited, not to any partner therapy. Claudia Estcourt is doing an RCT of accelerated partner therapy just now, and I will look forward for her results, and that will give answers on the individual level of APT in the UK then. So how should we go on with chlamydia control? In the absence of chlamydia systematic screening, I think what we can do is testing and good case management, and I think counseling and partner notification is very important. Patients should preferably notify at least the last 2 to 3 partners, and in selective cases we could give PIPT. But what I do think that we should do some extra efforts on those with potential of high transmission and repeat infection. Now it's time to come to HIV. I don't know how much time I have. 2 minutes. Wow. I'll go very, very fast. HIV partner notification is very important, and as you see, here you see figures from the STI clinics. In MSM, we found in the last 3 years 0.8% HIV. In those notified for HIV, we found almost 5% HIV, and also in those notified for syphilis, we found quite some HIV. 1/3 of all the cases of HIV found in our STI clinics in MSM is in notified people. This is when they come in. We also register when people have HIV, whether partners are notified, how many partners should be notified, what is possible, and whether patient referral is done or provider referral. And here you see what is published also previously, the percentage of partners which are notifiable and what is possible. It's much lower than the ones who should be notified. Can internet help? We use partner notification, a website in the Netherlands. That's a website where the provider makes a code for the partners, for the index case. The index case can log in and send with this login a notification to partners either by email or by SMS. 85% of the people use that anonymously, but they can also use it by name. We have Martin van Rooyen has shown, and it's recently published, that patients and partners like this site, but they are less inclined to notify for HIV than for other STI. Here I show you the results from this website for the last year. 167 codes were made in the STI clinics for HIV, and only 40% of them, of the index cases, used the code. But there is another gap. We had almost 300 HIV diagnoses, so no code was made for them. But you may wonder how many partners were notified. And those 66 persons notified 351 partners, and most of them that was done by SMS, and 95% was done anonymously. And as I said before, partners like to be warned on name. But only of those who were warned, only 2/3 of them accessed the site to see what they were notified for, as it is used for all STI. So internet is not the absolute solution. Patients seek other ways. And even when this website is used, it's certainly not enough in the case of HIV. I think it's a good addition to traditional partner services, but in the end, the patient has to have a choice, both in which technique and method to use, but also in the personal assistance he wants to have. Patient referral should be done with good counseling, but then the patient should not be left alone. But I think we always should phone patients after a week and say, how was it going? Can we help you? And in the end, provider referral would be the best. I will tell you in a minute why. But even when you do that yourself and when you do provide a referral, you have to follow up and the partners phone them and to try to get them in to get tested. Why do I think provider referral is important? There is quite some literature from Sub-Saharan Africa where they do provide a referral and where they have very good results in increase in testing of partners, and I think we can learn from that. Kind of summary for the HIV, I will come to an end. I think provider referral may be more effective, but the patient has to a choice, and we should listen to the people which we have diagnosed with HIV, as there may be issues around stigma and discrimination, and we should gain trust from them, and then we may be more allowed to notify partners ourselves. And in the end, I think also we should work together with all providers in sexual health care, GPs, STI clinics, and also HIV treatment centers, and we can help each other notify people. And certainly in the Netherlands, where the diagnosis of HIV, only 1/3 is made in the STI clinic, and from the other persons, we don't have any idea how that would go. And the last thing I want to mention, in the future, it may help, and I wanted to do a project with that. Could we not give tests, self-tests to index patients to try to, maybe that would increase partner notification. Thank you very much.
Thank you very much, Hannelore.